Assalamu alaikum. Good evening or good afternoon, whatever the time is with you people. Uh, we will be discussing how to manage intraoperative arrhythmias. Okay, so I don't think so. Any anesthetist who is in clinical practice would say that he's not able to face any cardiac arrhythmias during anesthesia. So, who would like to take the lead? Haifa, you are cardiac anesthetist, so I will put the ball on your court. So, what sort of arrhythmias an anesthetist can face intraoperatively? Haifa, can you listen? Can you hear?
Yes, Salam alaikum, Dr. Zishan.
Masala. So, like for example, come for instance, just come out of cardiac OR and think about a cardiac patient or non-cardiac, any patient who is under anesthesia. So, what sort of arrhythmias can occur?
Okay, difficult question. A lot of types of arrhythmia we can see during in the anesthesia. For cardiac lesion, for non-cardiac surgery, you mean?
Any patient, like you just consider any patient intraoperatively, what sort of arrhythmias can be there?
It will be يعني range from simple, not simple, from many types of. Let's
Just,
see
just,
like
just relax,
rapid.
relax. Just
Yeah,
start from tachy or brady. It may be any
yeah.
arrhythmia which is causing you a sort of
Yes.
tachycardia or bradycardia. This is one differentiation you can do. Or it
Yeah,
may be like,
rapid AF, rapid AF,
I'm sorry,
rapid EF, VT.
VT, like before that, before VT. What is the commonest of the arrhythmia which all anesthetists can see? Is ventricular.
rapid or octubic.
Can you speak a little loud? I think you are away from the mic. Uh, like premature ventricular contraction, PVC. PVC is the most, I think, frequent in addition to the normal sinus tachycardia. Okay, and any
Yeah.
patient during in conduct of anesthesia can go in sinus tachycardia because of this one
Okay.
because of light plane of anesthesia, analgesia, whatever. So actually, this is also an arrhythmia. Okay, so you in
Yes.
that way you are dealing the cause. You are increasing the depth of anesthesia. You are trying to see the cause. Maybe it's only the tube touching the carina, or inadequate anesthesia depth, or inadequate analgesia, or muscle relaxant, or there is some
Hypovolemia.
hypovolemia. Yes, like you will be going from
Yeah.
one side to the other side. Okay, so
Yeah, hypopnea. All this can
yes,
be caused sinus tachycardia. Yes.
yes. So whenever you have any arrhythmia, what are the things you would like to see?
First
Like
of
for
all, we have
example,
to diagnose.
if you have premature ventricular contraction, okay. So
uh,
what should be your approach? What you should be doing? What will you do?
First, we'll concentrate it on the number of the premature ventricular contraction, how the numbers. After that, hemodynamic of the patient is unstable or stable.
Okay,
Yes.
like you will be seeing how frequent it is. Okay, if
Yes.
it is occurring too frequently, it can go
Yes.
towards trigeminy, bigeminy, or
Yes.
ventricular fibrillation, because you are
Yes.
afraid of this thing. Okay,
Yeah.
so
Could
your
be.
approach will be hemodynamic instability. Okay,
Yes.
you will be looking at any hemodynamic instability with which is occurring with it. Like if maybe there is hypertension, maybe hypotension, maybe because PVC is an open-ended question. There can be any reason. It may be only the tube touching the carina, or it may be sign of ischemia. Like it can be because of anything. So you will be going step by step. Okay, and then usually we will target the cause. And if we just only consider PVC, then you will be doing ABGs. You will be looking at some electrolyte imbalance. Okay, maybe the
Potassium.
reason is
Yes.
because of low potassium, or any
magnesium.
like any other cause. Okay, so you will be treating that cause. So main question you will be asking will be the cause, hemodynamic instability. Okay, and at the same time you may consider, like if, for example, if you have a patient with known cardiac disease. Okay, so you have to rule out the dangerous things. What will be the dangerous thing? It will be ischemia. Okay, so at the same time you will be increasing the FiO2. You will be increasing the oxygen content of the, by any way, like according to the situation, you will be trying to maintain the myocardial oxygen demand supply ratio. Okay, so for that thing you will be considering all the removing all the stress. Okay, your approach will be to give analgesia. Maybe you are considering like all, you will be covering from one side to the other side. Okay, just please mute your mic. Okay. Okay, I think it's clear up till now. Okay, so what else about other than ABGs? Like if we go, I have taken example of PVC. It may be any arrhythmia. Okay, it may be bradycardia, symptomatic bradycardia with signs of instability. Like what will you say that sign of compromise? What can be the signs of compromise during anesthesia? Anyone can tell?
Sir, it can be hypoxia, hypotension,
What else?
and
Maybe
chest
patient,
pain.
maybe
But
hypotension and signs of low cardiac output. Okay, in the form of cold peripheries.
sweating.
Patient may be sweating. Patient may be sweating. Okay. What else? As I told that one of one of the cause of one of the if you consider big boss, now we have considered all the small minor things which are in your hands. You are increase the FiO2, you give the analgesia, you give the muscle relaxant, you increase the depth of anesthesia, you start looking at the cause, and these things are rolled out. So what are the other causes? It may be ischemia. Okay, so ischemia, you will be finding how can you pick that there is patient is having ischemia? Yes, Sumera? Who was answering? Yes.
Sir, on ECC, we can see ST elevation.
Yes, sir.
ST changes like
T-wave inversion.
T-wave
T-wave
inversion,
inversion.
or like it will be changes for ischemia or infarction. Okay, so it can be anything or anything else. What else? What is the result of arrhythmias and block? Yes. What is the next step? For example, if intraoperatively you are not able to manage arrhythmia, what will be the next step? What can happen? Yes, Sumera.
Patient may
Infarction.
go into cardiac arrest.
Yes, like it may patient may ending in having cardiac arrest. So it will be going towards that thing. Or before cardiac arrest, it may be something like if heart is going in failure. Okay, so maybe there is sign. No, just a second, please. Sumera, just concentrate. Let me ask the person. Yes, Sumera, can you just answer this question? What will be the next step? Sorry, before cardiac arrest, what sign you can see? And you see it. I guarantee you, if I am just telling you, you will recall everything. Usually, what happens in this scenario? Before cardiac arrest, if you are a patient having failure, you will see signs frothy sputum coming out of the endotracheal tube because of frank pulmonary
Yes,
edema.
yes, sir. There can be a decreased cardiac output,
Bradycardia.
and due to decreased cardiac output, there can be decreased end-tidal CO2.
Yes, like there will be you will have what I am telling you, that you have to look into the picture as a whole. Okay, patient may be going in hypotension before failure. Because a result of any arrhythmia, serious result will be if you don't treat the cause, or if there is something very fatal going on. So what will be happening? The step will be like this. Patient will have some arrhythmia going into failure. If patient is unable to maintain the cardiac output, there will be signs of failure. Okay. When there will be signs of failure, it may be evident in different scenarios, in different form. There may be hypotension, loss of end-tidal CO2, pulmonary edema, increased airway pressures, frothy sputum coming. So you should be ready for it, and you will be dealing it accordingly. Okay. So this should be in your mind. Whenever you are dealing with anything, you will be your approach should be like that. Okay. And actually at that time you can consider the causes of 5H and 5Ts, which we consider actually when the cardiac arrest has occurred, but actually you can consider those things at that time as well, because only the arrhythmia may be the first sign of any impending problem. Okay. So this is how you would be approaching. Okay. So things are clear up till now. Okay, so usually if we for instance, if we only focus on the tachycardia, how will you, like, if you just consider the algorithm for tachyarrhythmias? Okay, so just imagine, because you all have done ACLS, and everything is written. I can open the ACLS algorithm, but I'm just want you to think critically, because practically we are dealing practically the arrhythmias are not following the ACLS protocol. So you have to anticipate in a clinical way rather than only the bookish way. Am I right? So how will you deal the tachyarrhythmias? Yes. Usually.
Sir, cardiac massage.
No. Cardiac tachycardia.
Carotid.
Shock
Sorry,
absorption
sir,
cause.
carotid. Sorry, sir, carotid massage.
According to
No,
the hemodynamic.
just a
If it
second,
is
please.
hemodynamic.
Just a second, please. The one who want to answer, raise the hand, and only that person will speak. Arsalan, you want to answer? Please speak out. Yes.
Yes, sir. Initial we do carotid massage. If
No.
carotid massage fails,
How did you decide that it is SVT? Straight away you decided? Just by looking
no,
at the
sir.
rate? Would you like to see
No, sir.
something
ECG tell
else?
us.
Sorry?
ECG tell us, sir.
ECG
ECG
tell
tell
what?
us.
ECG will tell what?
Either it is monomorphic or polymorphic to tachycardia or supraventricular tachycardia.
First of all, if it is regular or irregular. Okay. First of all.
Yes, sir.
Okay. If it is regular, for example, for instance, if we say that it is regular, what will you do? What will you see next? How will you pinpoint that it is? You will be looking at broad complex or narrow complex. Am I right?
Yes, sir.
Okay. So now you see that it is narrow complex. Now what will you do? Would you like to see
Sir,
the P wave?
control the rate.
No. Please, you are
Yes, sir.
jumping. You are directly jumping to next step. Would you like to see the P wave or no?
Yes, sir. Of course, we see the P wave.
Okay. If P wave is there, that it may be on normal sinus tachycardia. Okay.
Yes, sir. Sinus.
If P wave is not there and rate is very high, okay, then you will be doing the carotid. Now I will let you do the carotid sinus massage. Okay. You are very eager to do it without even checking the P wave. Now you are allowed to do it. Okay. Now you do the
Okay.
carotid sinus massage. Would you like to do it on both sides or one side, or is there anything in which in scenario you will not do the carotid sinus massage? Is there anything
Sir,
in which?
sir, we do on one side. because on both sides there is a chance of vagal syncope. So we
Vagal, so
avoid it on both sides.
okay, you will not do it once both sides. This is one thing. Would you like to do it? Would you like not to do this vagal maneuver? And there are some other vagal maneuver. You would like to choose them in some condition in which you will not do the carotid sinus massage. What is that thing? If a patient has a history of carotid artery disease, cerebral vascular disease, okay, and you know, or you have clear-cut symptoms of patient having TIA, in that scenario, you will not do it. Because if there is a clot, you may dislodge that clot at that time. Okay. So this is something which should be in your mind. If you have extreme, you can do what else? What other carotid maneuvers would you like to do? What are other carotid maneuvers? Anyone else want to answer? Just raise the hand. What are the other carotid sinus? What are the other vagal maneuvers? Yes, please. Answer, please. Dr.
Yes,
Sharir Ahmed. Yes.
Valsalva maneuver.
Like Valsalva maneuver, how can you do intraoperatively?
Intraoperatively, patient is on ventilator. You have to put it on a manual ventilation and close the APL wall for a 30 millimeter of centimeter of water. Then give sustained. Sorry.
Like you are giving the increased airway pressures for sustain
Yes,
for
30 seconds.
For 30 to 60 seconds up to the according to the scenario. This is one thing. What else? Any other
And
thing you can
patient is if patient is not on ventilator, if we
Yes.
can tell them to blow
Hold the breath.
hold the breath, expire against closed glottis.
Yes, this is you can do. There is another vagal maneuver which they now stress in the ACLS. What is that one?
Blowing the.
Oh, putting the ice pack on the forehead.
Yeah.
Okay. So on the eyes and forehead. So this is what they sell now. Okay. They stress that thing. Okay. So you did the vagal maneuvers and you fail. What will be the next step? Would you like to see anything else at the same time? Who wants to answer, please? Yes,
patient
please.
is hemodynamically unstable.
Or
I'll check
stable.
the blood pressure or stable.
Okay.
Yeah.
If it is patient is stable, stable
patient
SVT,
is
what will you do?
Stable SVT, I'll go ahead with.
I cannot hear you, please. What will you do in stable SVT? Your voice is gone. Anyone wants to answer, please? What is the drug of choice at that time? Arsalan, would you like to answer?
Welcome.
I am sorry, actually, I was disconnected.
Yes, I was telling unstable and stable. If patient is stable, I will go ahead with adenosine 6 milligram, that 2 syringe technique. So I'll give one with adenosine IV push and followed by 20 ml of saline bolus and raise the arm.
Okay, then what else?
And I'll check again ABC.
Is there any contraindication or any consideration or anything would you like to see if you are giving
sorry,
adenosine?
I forgot to tell. If patient is awake, I'll explain the patient. There is a chance of chest discomfort it may cause. So I'll explain that. And it is usually not given in patient with bronchial asthma.
Yes, it can aggravate that thing. And another thing you have to think and consider. at that time you have to bring the crash cart as well. When you
Yeah.
are giving, actually you are doing what are you doing actually? There is one electrical cardioversion, okay, and there is one
Okay.
pharmacological cardioversion. So at this point, when you have failed the common maneuvers, actually you are starting the cardioversion, and cardioversion can result in actually cardiac arrest. There is possibility of cardiac standstill by giving a bolus of adenosine. Okay.
Okay.
So you have to be careful about it whenever you are giving adenosine. Okay. So
Okay.
what else in addition to that? You did the ABGs and another anything would you like to do at this point? You
Yeah.
were
So
only
after
looking.
giving,
Just a second. We
after
are
giving,
because I'm sorry to interrupt you, because at the moment basically we are focusing on intraoperative. Okay, so you
okay.
are only have the screen. So would you like to do
Yes.
anything else?
Yeah. Again, we have to check it. It's the same thing. The rhythm. If it is
No.
not improved.
Sorry. Sorry. Actually, I want you to just think about it real time, because this is not written in this way in the books. Okay, so that's why sometimes we forget. You have to
Yeah.
do the 12 lead ECG.
Yes.
Okay, you have to do
Okay.
preferably 12 lead ECG, because the rhythm you can pick in a better way in 12 lead ECG rather than only the monitor screen. Okay, because there are so many
Yeah.
factors which can distract you, so you have to do the 12 lead
Yeah.
ECG as well. Okay, at the
Okay.
same time, would you like to do anything else if you are considering any other cause than the pure like reversible cause or something like that? You can have Dr. Jafar, can you close the camera please? Jafar Khan, your camera is on, please.
So we can, if it is a hypovolemia, we can give IU fluids to correct it and correct any hypoxia if it is there, and give 100% oxygen. And yeah, that's all I can think.
I'm sorry, I was a little bit distracted by the that fellow. Yes.
Yeah.
So
So
what you will be doing?
yeah, if it is like if it is hypovolemia, if you can see, you can correct by giving a bolus IV fluids and correction of hypoxia. And is there any?
You can get expert opinion. Actually,
Yeah.
thing is that in ACLS they are telling you something else. So we are at the moment we are just thinking real time. Okay, at this point
Yes.
of time you can do a 12 lead ECG. You can send the labs. Okay, you can send the labs. You can call cardiology at this point of time. Okay, you can send maybe if especially if you are considering a patient at risk, like any diabetic patient, hypertensive patient, because maybe this is a sign of underlying ischemia. Okay, so if you are
Okay.
thinking on that ground, you can send the cardiac enzymes, 12 lead ECG, cardiology opinion, because at real time you are managing thing in a different way. Okay, so I'm telling
Okay.
you not only the bookish, the practical aspect as well. Okay, so you
Okay.
gave
Okay.
adenosine. What else? What other options you have in addition to adenosine?
We can give beta blockers.
Beta blockers. What else?
Like metoprolol, 3 to 5 milligram
Is
IV
there
over 10
any
minutes.
medication better than metoprolol?
Esmolol we can give. And amiodarone 300 milligram IV over 20 minutes we can give.
Okay. Sorry. Beta blocker. What else?
Amiodarone.
Amiodarone. In beta blocker, you told about metoprolol. Is there any
Yes.
other beta blocker which is better than metoprolol in
Esmolol.
this scenario? Esmolol.
Esmolol.
Okay. Because it's a short acting. So it is better to give esmolol, because it will correct it quickly, and there will be no long, like it is not long acting. Okay. So
Okay.
you will bridge the time in which you are trying to find the cause.
Yeah.
Okay. Because if you give a long acting beta blocker, what can be the problem?
Like patient may have hypotension in the later stage.
You don't know what is the cause at the moment. Am I right?
Yeah.
For example, you gave a long-acting beta blocker, and it was actually a preceding failure. Okay, so you give something which is actually depressing the heart. So it is better. I'm not saying that it is, because at that time, nothing is 100% safe. You are entering in a danger zone. So you have to consider all the pros and cons of whatever management you are giving. You told about amiodarone before that there is another medication just like beta blocker, calcium channel blocker, especially
calcium channel,
which is verapamil. Why you will not give amlodipine or deltazem?
I think verapamil has a faster onset of action compared to amlodipine.
No, this is not the answer. It is cardioselective. Okay, amlodipine is a peripheral calcium channel receptor, and deltazem can be given, but verapamil is specifically cardiac, and if you are treating the tachyarrhythmia, verapamil is a better choice. Okay. So you have done all these things, and then you can repeat adenosine. The other things you can find written in ACLS, but I just wanted to have your brainstorming regarding this thing. In this scenario, for example, now patient is becoming hemodynamically unstable. What will you do?
If hemodynamic unstable with SVT, I'll go ahead with cardioversion.
Okay.
DC
so
cardioversion.
how much is the dose of cardioversion?
Initially with 150 joules.
150 joules for SVT?
Sorry, I think I'll correct. I think 50 joules initially.
50 joules. Okay, if you have a baby of 4 kg, you will give 50 kg, 50 joules.
No. This is, I think.
What would you like to do?
I'm not sure.
You are, because you are confused, and because you lost your confidence, that's you are not able to answer. You know it.
Yeah, there may be 4 joules per
2 to
kg.
4 joules per kg. Am I right? I think it's like that. Anyone can correct us, because these doses and these always stink me. I'm always
I think
bad
someone
in.
has written 2 joules per kg.
Yes, it is 2 to 4 joules per kg. Okay. So remember one thing in the exam, this is the only difference in the exam, that in the exam, they are not asking you from one page of any book. Okay. So they are actually twisting you and turning you, and they are putting you in a roller coaster. Okay. So if you practice in that way, in the exam, you will be smiling. Okay. But if you just try to trust only the book reading, the examiner is smart enough to know whether you are having the critical thinking, or you are only trusting the bookish knowledge. Okay. So that is my message to everyone, that never follow a specific book, because it will embarrass you real time. Okay. So it is better to be logical and understanding in a conceptual way. Okay. So this is one thing. If a patient is awake, like you were saying, so would you like to do something?
Yeah, so patient is awake. Before giving adenosine, I'll give sedation. And before giving cardioversion, I'll give sedation.
Would you like to delay it, or would you only prefer, if it is available, if it is possible, you will wait for it, but you will not delay the this one cardioversion for it. Okay.
Yeah.
So this is for the algorithm or the management for the SVT. For example, we just come back, and now it was atrial fibrillation. Okay. So what will you do?
Atrial fibrillation, I have to
Now we have made the
base.
base. Okay. Anyone else? Would you anyone else like to answer? Yes, Dr. Khalifa, would you like to tell about atrial fibrillation? The same scenario, we have the baseline. So what will be different from SVT in atrial fibrillation? Would you like to answer? Okay, I think you can continue. You can continue.
Okay, in atrial fibrillation, the ECG findings includes there is a loss of discrete P waves, and rhythm is irregular and narrow QRS complex, and that fibrillatory waves can be seen, and its rate may be from 90 to 170. And yeah, this is the ECG findings.
Actually, absence of P waves, bizarre ECG.
Yeah.
Bizarre
Yeah.
ECG, no clear P waves, and rate more than, how much should be the rate?
90 to 170 ventricular rate.
Okay, so what will you do in this scenario other than what we have told, what we have discussed
Yes,
up till now?
again, it depends on the which type of AF. It is a new onset AF or a persistent AF. If it is a new onset AF, if it is less than 48 hours, patient is hemodynamically unstable, I'll go ahead with cardioversion, that is synchronized cardioversion with R wave.
Now my question is that if you don't know about the duration of atrial fibrillation and you have a hemodynamically unstable patient, what will you do?
Yeah, so in this condition, I will go ahead with the cardioversion. And if we
Yes.
have
So
a transesophageal echo to rule out any
this will
atrial
be
thrombus.
because in real time scenario, if your patient suddenly goes in atrial fibrillation, or this is or that you are dealing an emergency patient, you started the case and you found to have atrial fibrillation. Okay, so in this scenario, you cannot follow that algorithm. Okay.
Yeah.
In that scenario, you have to do the cardioversion, because if you don't do it, patient will be lost. Okay.
Yes.
So in that time, at that time, you will be, otherwise you will be ruling out the clot, and if there is clot, you will be starting the anticoagulation. Okay.
Yes.
So that is a separate thing, but intraoperatively you will do the cardioversion. Okay.
Okay. Yes.
And this we just missed this point that this sort of cardioversion is called as synchronized cardioversion, and you are synchronizing it with
R wave.
R waves. If you don't synchronize it, what will happen?
Yeah, patient may go for ventricular fibrillation because we are stimulating during refractory period.
What is what we call that phenomena, R on T phenomena. Okay.
Yeah. Okay.
And another thing is that how this synchronization is occurring. There is a for that, how you have to put the ECG leads. Okay.
Yeah.
So by that, sorry, with that monitor, it is synchronizing. Okay.
Yes. Okay.
So now you have come to a few words about amiodarone. So amiodarone, like what are the things you should be considering when you are giving amiodarone?
Amiodarone is class 2, class 3, class 3 antiarrhythmic. It has potassium channel blocker, and it has a beta blocker activity also. And the thing we should consider is we have to give in usually large veins, usually in central vein, or else veins in antecubital veins we have to give. And chances of bradycardia and hypertension after a bolus dose, we have to keep it in mind.
Okay, what other systems in amiodarone involves?
Amiodarone might cause pulmonary fibrosis and corneal deposit in long term.
Okay, what is the most important? Why you are giving in only one dose? Have you thought about it? Vaji, I will just come to you. Or I can take your question first. Vaji, you have raised a hand. Can you ask the question what you are asking? And in this time, you can think what I'm asking you. Yes, Vaji, would you like to ask any question? You have raised the hand. Okay. So did you get my point? Why we are giving it in a single dose?
Yeah. Loading dose we are giving 300 milligrams.
Why? Did you ever think any other medication? Do you know that we are giving like that? We are only giving 300 milligram and then forget. We are giving 900 milligram over next 24 hours and that's finished. Why? What's the reason for it?
Maybe it's a long acting, like it has
Long acting, it has terrible volume of distribution
yeah, high
in maybe
volume.
460 liters or something like that. So it will
Yeah,
take many days to be removed.
yeah,
Okay.
36 days, something like that.
So that is the reason. Long hive is the word, but actually for that, and it is involving not only you told about pulmonary fibrosis, it causes liver dysfunction. It can cause further arrhythmias. It can cause it has association with thyroid dysfunction. Okay, and
Yeah.
pulmonary fibrosis might take time, but thyroid dysfunction can occur in earlier time than fibrosis, I think. Okay.
Okay.
So these things they can ask you in MCQs as well as in oral part they can ask you this thing
Okay.
as well. Okay. So amiodarone is actually a medication which has a number which you if you are not able to treat any arrhythmia or you don't understand what sort of arrhythmia is it is just like a blind attack. Okay. So
Yeah.
amiodarone is being given in that scenario. You are giving in cardiac arrest as well, ventricular tachycardia, atrial tachycardia. You are giving it if you are not finding any other result. Okay. So this is some words about it. With reference to atrial fibrillation, you have to know the duration. In emergency, you have to cardiovert it. In if otherwise, you will be doing the rate control with beta blocker and rhythm
Yeah.
control with amiodarone. Okay, so
Yes.
it goes like that. Anything else you want to tell about atrial fibrillation? Acute management.
Uh, yeah, I think if patient comes with atrial fibrillation for elective surgery, we can
Mhm.
do risk stratification with the Chadwa score for
Yes, that.
stroke.
Yes. Okay. And actually, you will not be doing any elective case unless you
Mm.
start the
Yeah, we'll control.
uh, yes, you have to control it. But in emergency, it will be you have to proceed with the risk
Yeah.
stratification. Okay.
Mm.
You can take arterial line, you can have cardiac output monitor
Yeah.
or things like that.
Yeah.
Okay.
Yeah.
Like extra, in addition to standard one, standard two monitoring, you will be doing these invasive monitorings to be on the safer side. Okay. And as you will be having relatively less invasive type of anesthesia, less invasive type of surgery, and minimum invasive things you will be doing. Okay.
Yes.
Trying to reduce the stress on the body in this scenario.
Okay.
Okay. What else?
Then we
Anything
have
else?
to treat, we should know the precipitating factors for atrial fibrillations. We
Yeah.
can
So what are the
classify,
causes of atrial fibrillation, by the way?
cardiovascular, respiratory, metabolic. So
Mhm.
cardiovascular, history of ischemic heart disease, valvular heart disease, and
Mhm.
then respiratory pleural effusion, pneumonia, and then metabolic causes like acute
What
alcohol
is
tox,
one of the most common non-cardiac cause of atrial fibrillation?
alcohol toxicity, acute alcohol toxicity, and
What
metabolic
else? No, in
thyrotoxicosis,
thyrotoxicosis, sepsis. Okay.
and electrolyte imbalance like hypokalemia, hypomagnesemia, or old age is also a risk factor for atrial fibrillation.
Yes. Fine. Fine. So, what else? What else? Like you will be looking at the cause, ischemic cause, valvular heart disease. Which valvular heart disease it is the most common? Atrial fibrillation and why?
Mitral stenosis
Very
is
good.
the
Mitral
most
stenosis and why?
because of mitral stenosis there will be a left atrial enlargement which results in uh, atrial fibrillation and
Actually, you
stasis.
can say that it is most significant there because in this scenario, if the patient goes in atrial fibrillation, whatever, because now the heart is dependent a lot on the atrial kick. Okay. So
Yes.
if the atrial kick is lost, then it becomes very difficult to maintain the cardiac output. Okay.
Yeah.
So that
Okay.
is the one of the most critical reason in addition to the ischemia or anything else. Okay. So few words about stable VT, because unstable, pulseless VT and VFib will be in cardiac arrest. Okay. So Waji, would you like to ask something, because your raise is again, hand is again raised? Would you like to ask something? I'm sorry, I cannot hear you. I'm sorry, we cannot hear you. None of us can hear you. Okay. So we will continue. Like ventricular tachycardia. Like what sort of ventricular tachycardia can be there? PVC is, by the way, is sort of ventricular tachycardia. Okay, is an example of ventricular tachycardia. It will be it will be broad complex, and then this one, if it is stable VT, what will you do? Yes, in stable VT, what you do? You can continue, because there is no other volunteer, so you can continue. Dr. Sharira, you can continue. Okay, in stable VT, we give what medication? Anyone? Arsalan? Yes, Quratul N. Yes.
So amiodarone, fast stability.
No. There is something before that you give.
Lidocaine.
Lidocaine. Even in PVCs, you do like that. Okay. So lidocaine, if lidocaine is not working, then you can give amiodarone. Okay. And now it becomes unstable. What will you do?
So defib.
Not defib. Unstable is something else, and pulseless is something else. Unstable, you have to do the cardioversion, synchronized cardioversion. Okay. Defibrillation is called unsynchronized cardioversion. Defibrillation is unsynchronized cardioversion. Okay. So in this scenario, you do the synchronized cardioversion. If patient with VT become unstable, signs of instability, which we have already discussed. Okay. Diaphoresis, low cardiac output, signs of failure, low blood pressure. If patient is awake, signs of unconsciousness, syncope, we all know about it. Okay. Yes, Quratul Ain, are you interested in answering something? Your hand is raised. Okay. So what else? Because cardiac arrest is a little, I'm not going in that detail. I'm going towards bradycardia. Okay. So bradycardia, how you treat it? What sort of bradycardia you can face? What are the things in which you can face bradycardia? Yes, Arsalan.
The succinylcholine.
Okay, one that, like,
And
remember one thing, to answer any question, divide, you can speak out the word with it, or you can think like that: anesthesia related, patient related, surgery related. Okay. Now, what are the anesthesia related causes of bradycardia?
so drug induced, most likely succinyl overdose.
Any other medication? Any other medication, if you are giving that can cause bradycardia, or any other step of anesthesia in which there can be bradycardia? Because actually bradycardia, anything will be related to vagus. Okay. So it may be any surgical reason, anywhere. If there is eye surgery, oculocardiac reflex, cervical dilatation, bradycardia, anal dilatation, bradycardia, laparotomy or laparoscopic surgery at the time of creating the pneumoperitoneum. If the depth of anesthesia is not good, there are more chances of having vagal mediated bradycardia. Okay. Or for example, in laparotomy, they are pulling the mesentery, it can cause bradycardia. Okay. In middle ear surgery, if they are having high pressures, it can cause bradycardia. Then if you are having high airway pressures, it can cause bradycardia, because that we just discussed that we are using it for treating tachycardia. Okay. So that is one of the cause. So in the medication, the patient factor may be what may be the patient factors?
So maybe patients suffer from heart block, type
Heart
1,
block.
type 2, type.
Very good. Like heart blocks are usually because of what reason?
So AV induction blockage.
No, there may be some congenital cause, but usually they are ischemic. Okay. If
Okay,
there is
sir.
ischemia of SA node, what will happen? Patient will go in bradycardia. Am I right?
Yes, sir.
So what else? Like just think about it and you will find the reason. Okay. So then you what will, I'm sorry?
Hypothyroidism.
Hypothyroidism. Yes, fine. You can go into the details of bradycardia, but think about it. One is anesthesia related, one is patient related, and one is surgery related. Okay. And then you will be approaching in that way. Okay. So you will be, for example, maybe tube touching the carina. Usually it can cause tachycardia, but it can cause bradycardia as well. Okay. Because that area is also the area of the vagabond nerve. Okay. So you will be treating it like that. When will you be treating bradycardia and how?
Sir, ये cranial, please repeat about cranial, sir, please.
When tube touching the carina, in majority cases, there is tachycardia, but it can cause bradycardia as well. Okay.
Okay, sir.
Any airway reflexes usually causes tachycardia, but they can cause bradycardia as well, because the area is of vagus nerve. So you, wherever vagus nerve is wandering, you can expect bradycardia. Okay. So that is the main theme. And when will you be treating bradycardia? When it is symptomatic.
It's causing hemodynamic compromise.
Hemodynamic compromise, the same hemodynamic compromise which we have discussed before. Usually hypotension can occur and the trend is going down, and you have to look at the baseline heart rates. You have to rule out that, for example, if there is a hypertensive patient and your patient is on beta blocker and you treat the treat the bradycardia, you will have crazy blood pressures. So you will have low threshold, even up to 40. If, for example, patient is maintaining the hemodynamics, you will not give anything. Or even if you are giving something, in that scenario, when you know the patient is hemodynamically stable, if you want to give, would you like to give glycopyrrolate or atropine?
Atropine.
No. In that scenario,
No, if
you will give,
hemodynamic stable, then we can give glycopyrrolate.
no, like even I'm not talking about the, like, for example, if you don't want tachycardia, okay, because atropine is short acting. Okay. Atropine is practically for actually for rescue. Okay. But if the trend is going down and a patient is collapsing, then you have to give atropine. Okay. But I am telling you this thing, maybe the books will not agree to me, but practically I'm telling you that if you know there is a specific cause and you don't want tachycardia, it is better for you to try with glycopyrrolate first. But if it is, the things are not in getting your control, you can wait for a few minutes and then you can give atropine. Okay. So because you don't want tachycardia, tachycardia is a killer. Tachycardia is a killer. Okay. So you only want to avoid bradycardia. You don't want to do get tachycardia. Okay. So that is why in specific patients and extremes of age, in patients with the ischemic heart disease, in patients with hypertension, it is not advisable to give without any reason atropine. Atropine is a disastrous medicine. Okay, atropine is not a nice medicine unless it is used with a proper reason. Okay, so this is important point. And then in other way, if you are failing, there are the things which are written in the ACLS. I'm not too interested too much, but they are using. I have never used even I have never seen glucagon. It has written over there. I have never seen people using dopamine for it, but you can give dopamine, you can give epinephrine. But usually, practically speaking, you are treating the cause, you are going in a proper way, and then epinephrine is a better choice. You can try with epinephrine. Okay, especially if, for example, patient is beta blocked. Okay, so maybe you need the direct acting. Okay, because atropine will not be working. In that scenario, it is better to go with direct acting. Can someone answer this question? Why in beta block patient, the vagus will not help much? How atropine causes tachycardia? What is the mechanism of action of atropine?
Anti-muscarinic.
Anti-muscarinic. Okay. So what it is doing? It is vagolytic. Okay. But for example, already the involvement is not because of vagus, it is because of the other system. You have blocked the beta receptors. So the effect will not be that pronounced. That's why in patients who are dependent or having very good beta blockade, maybe you don't need to have direct acting. Okay. Which are acting directly on the receptors. Okay. So
sir,
next step. Yes.
Sir, when there is beta blockade, even direct acting will not be effective.
So
we need glucagon in this situation.
Have you ever used glucagon?
Yes. No, I have never used, but in medicine book it is written when there is beta blockade, use glucagon.
Yes, you are right. You are absolutely right. But at least it will have some effect better than atropine. Okay, because at that time atropine will not affect. Atropine will not affect. Okay. So you can go for epinephrine. Anyways, what will be the next step? We will not go in details of pacemaker. We will discuss in our next setting, inshallah, pacemakers. And the next thing is to do the pacing. Okay. If you fail these things, then you will be doing the pacing either with the temporary pacemaker or with the permanent pacemaker.
Permanent.
Later on. Like temporary pacemaker may be transcutaneous. Okay, there are pads just like, and then you can place it with the CVP. Okay, and this transvenous, and if it is like it requiring, then you will be planning the patient for. You will keep the temporary pacemaker, and then you will put the permanent pacemaker. Okay, so this is how you deal intraoperative arrhythmias. I just try to give you the practical aspects more than the pure bookish, because books you can always read. That is more important to have the concept. So baseline, the messages are, you don't treat only the arrhythmia, you treat the patient. So your answer will be that you will be treating the cause. Okay, I've intentionally excluded some of them because we will discuss it separately, as long QT syndrome, torsades. There's some I have excluded intentionally. Cardiac arrest we will do separately. And this is the basic arrhythmias: tachycardia, bradycardia, atrial fibrillation, SVT, VT, PVCs, role of lidocaine, use of beta blocker, use of calcium channel blocker, use of amiodarone, use of cardioversion. So this I have just given you an idea about it, these things. And any questions? And Vaji, you were asking this question, so I think you found the answer, that you will be, if it is not responding to cardioversion, you will repeat it and then you will get the expert opinion. That's what usually we are doing it. Okay. Any questions before we finish?
Sir, on a defibrillator, there is one function of pacing. Could you please explain about this?
Tayyab, frankly speaking, I'm not very expert in it. I think it has somewhat the similar function of you have pointed out the thing which I don't know actually. Okay, I think it is just like the pacemaker, but I'm not sure about it. Okay, anyone else if anyone else knows about it, you can explain. If anyone knows about,
We can use
yes, yes, Qaratulan, what you are saying?
we can use this pacemaker as a transcutaneous pacing in case of emergencies. Like it has two pads. We can arrange these pads in the similar fashion as we are doing for defibrillation, and we can
Yes,
attach this lead. Like I have seen somewhere
yes, Tayyab, I
they're
was
using it
also has
as
the
for
same.
transcutaneous pacing.
I also has the same answer in my mind because I have never done it, so I cannot comment it, but it should be like that. If it is a function of pacing, it should be like that. Okay. Because actually
Yes, it is.
it should be like transcutaneous spacing as Qaratulan told. Okay.
Okay.
So thanks everyone for your presence. And if any question, you all are welcome to contact anytime on WhatsApp and anything. I will, because I put all these recordings in the YouTube channel. You can all subscribe to the channel, and I have made the playlist. The people who, because before we used to do it in our native language, our Urdu or Hindi language, but since last few months, around 4 to 5 months, all are in English. So you can find all the playlists, all the English discussions I have put in a separate playlist, but separately all whatever topics we discuss, they are automatically put. I put it in the playlists. Okay. So if you find any problem, you can contact anytime. Okay. So thank you very much. Bye bye.